we'll talk about, but anyone have any interesting cases that they want?
Yeah, I'll start it off. This is one from the ER, but it was brought to me by paramedics. It was I think it was mid-50s-year-old patient. His main complaint and the reason he came to the ED was he was profoundly vomiting for a couple of days. History of hypertension, not taking medications. Otherwise, I believe he was borderline diabetic is what he said. The medics had placed an IV, they gave him a little bit of fluid, they gave him some Zofran, he was still vomiting. They saw me when they walked in the door, they're like, hey, would you mind coming over here? And they tell me that the guy, he was kind of a little bit altered. He was bradycardic in the 40s, and his pressure was too high for their monitor to measure it. I'm like, all right. So walk over. They give me their pre-hospital EKG. You know, when they were telling me that the patient was bradycardic, they were right. And along with that, it was actually a sinus bradycardia. So that was good, but it was the QRS was beginning to widen out a little bit, and the T waves were slightly peaked, let's say. No history of any renal disease, you know, this questionable borderline diabetes, and this pressure that's far too high to even be measured. So, you know, obviously right off the bat, I was like, okay, let's give this guy some calcium. You know, at least we still have a decent heart rate. He's still sort of maintaining. Which after 2 grams right off the bat of chloride, his heart rate came up to like the 80s. Pressure was 320 estimated over about 240, because even a manual blood pressure cuff only goes to 300.
Yeah.
So we had that maxed out.
Some people call that patent pen.
Yeah, yeah. So, you know, I know we all have our different options as to how we like to lower our blood pressure, and my initial for him was to start labetalol, and the way it's meant to be started, which freaked a lot of people out, you know, because as we know, your basic dose is 20, but then every subsequent dose doubles, and you have a lot of room to play with. Once I got to 160, pharmacy was not happy with me. So I actually switched him over to a Tridal drip with pushes, since I can, you know, we can manage that ourselves, just like pre-hospital they can do so. So his drip, I started at 300 mics and then was giving pushes every 2 minutes until his systolic was measurable on the non-invasive blood pressure. It took that drip, 6 milligrams of pushes, and then 15 of cardine to get his blood pressure to 220.
Oh boy.
Yeah.
So before you break the news on like what was going on, like there's a couple things that I like to go over and think about, especially from the pre-hospital standpoint. Is so this patient presented, you know, nausea, vomiting for the past couple of days. He has a blood pressure, so that's good, but you can't even measure it because it's so high. You know, usually what I'll try to do is with a manual cuff, which I know is sometimes hard to find on an ALS rig, is you know, I'll feel for a radial pulse and see if I can pump up the pressure, because sometimes it's just because their pressure is so labile, or the patient's moving too much, or you know, you didn't really take off their coat and you're trying to do it through their coat. So usually I try to get at least a palpated blood pressure. And in this case, it would have been all the way up, and it's like, oh, and there's still a pulse. Crap. So that's one thing. And of course, you gave calcium right off the bat. You kind of hinted why. Does anyone want to throw in anything else? So he gave it for the hyperkalemia, or suspected hyperkalemia. So I'll check for ports or anything. This guy could talk to you, so he can tell you if he has renal disease. But there's always a possibility that there's this new onset renal failure, and he could be hyperkalemic from that. Is there anything else on the differential? Especially with this profuse vomiting.
And you got vomiting, you got extreme hypertension, you got patient becoming bradycardic.
Exactly. That was the other question. Mm-hmm.
So we're worried about some sort of head bleed, or it could even be a subdural. A lot of times, like the classic case for me for like some sort of brain bleed is he was fine, and then we heard a thump, and then he was out for a couple seconds, and then now he's awake, super high blood pressure. I'm just like, this is a bleed. And for me, I rush them straight to the CAT scanner, get a CAT scan, and then plus or minus intubation when they get back, because they're talking to you, or a lot of times they're a little bit altered, or maybe they're lethargic.
Yeah.
So I don't know that this is the case for this, but those are the things that are going through my mind when I see a patient profuse vomiting. What's their mental status, what's their glucose, things like that.
Yeah, that was the next thing on the list of things that we did for this gentleman. Because he was maintaining so well and he didn't have any kind of deficits or anything like that, and it had been going on not for a couple of hours but a couple of days, I decided to manage that blood pressure somewhat prior to getting his CT scan, which we got the scan obviously within a very short period of time, and there was no problem with it. However, he was, shockingly, new onset renal failure. I know we're all amazed by that.
But that's an important thing, that just because they aren't already on dialysis,
Right.
just because they're not
Exactly.
chronic renal failure, doesn't mean they're not hyper K.
Yep.
Or they have some sort of disease.
Yeah.
Because sometimes that's the first time that you find out is when they're in extremis.
Yep. And the paramedic that brought the case to me, he had discussed it with a physician, and he also thought that maybe some calcium would be warranted. They wanted to hold off, which it's a judgment call on when you're taking a medical control call. My personal view is you're not going to hurt somebody giving them some calcium.
As long as you have a good IV.
Yeah, exactly.
Calcium, the only thing calcium's not good for is hyper calcium.
Yeah. Exactly. And
It's early.
that rare case, that's okay. You can give them some water after the fact. It'll be
Exactly.
fine. But I never withhold it. Anybody has any thought on it, pre-hospital, when they call me, I never say no.
So here's a question for you guys. So is there anything about this case that you guys want to discuss a little bit, or you have any thoughts on? Would you have done the CT first before controlling the blood pressure?
I don't know. I think I could have gone either way. I mean, if you got somebody's blood pressure that's so high, it's above 320, you still have a pulse with a manual cuff. I think I would have done what Dan did. I would have started IV medication right away. I mean, you got him on 3 IV push medications for blood pressure, and only got him in 220. So I think you don't even have a measurable blood pressure where you can document you went down 25%. So I think you start slamming stuff in and get him over. I would agree. I would say.
I think you have to balance that. I mean, if he's not stroked out already, he is getting ready to. So again, control the blood pressure quickly. If you want to take some labetalol to CT with you and do it that way, you could. Not 100% sure, but I don't think either way was wrong.
Mm-hmm.
Why labetalol in this scenario, and what other drugs you could have used?
Well, labetalol in general is nice, because it's push, right? Obviously, nitroglycerin is a great push dose medication for blood pressure. For somebody that I want to really move their blood pressure quickly, specifically for, I hate to even use the term, but hypertensive emergency, okay? I can really knock a pressure down, usually, not in this guy, but usually I can knock pressure down to whatever I want it to be relatively quickly and not kill their heart rate.
Yeah, that's what.
Obviously, there is a little bit of that, but this guy's heart rate after the calcium right away, his heart rate was up in the 80s roughly, so I wasn't concerned about that. And honestly, it's faster than the Trital often, because I could just give it in massive push doses, but nursing is going to want the pump set up, and you got to prime your tubing and you get all that going, which sometimes can happen quickly, but labetalol pushes are always ready to go. Unfortunately, I found out that we don't have the 200 milligram vials laying around right now in the ED Pyxis, so that was kind of a pain, but we made it work.
And I know in these situations, I like my heart rate because
Yeah, I think that's what it is.
We did.
The idea that if there was a bleed, then you're gonna hopefully limit that vasospasm
Yeah.
from the blood products. Also, because on my differential would also be, like press, and also, like you said, in a hypertensive emergency. Because by definition, if you've got neurologic deficits and severe hypertension, you have a hypertensive emergency. Because you've got that end-organ damage. And I would always treat the blood pressure as soon as I saw something like that, specifically because if they're like herniation, you don't want to watch somebody herniate in a CAT scan, So I would treat that blood pressure as quickly as possible because under most recommendations, they still say decrease the blood pressure by approximately 25% in the first few hours of, any sort of like if you're having a hemorrhagic CVA. So I think that, you're not going to go wrong by treating the blood pressure on the way to the CAT scan.
Yeah, I agree. Especially in a patient who's bradycardic.
Would have thought you had a, I would
Yeah,
put money that you had a bleed.
Cushy.
But that's just,
Yep.
I think to me that's the biggest question is how much do you try to lower his blood pressure? You're going to lower it, and he's got EKG changes and everything else. But what's your goal? Normally it's mapped down 25%, right? Somewhere in that range. You do that on him, bring it down maybe into the part where you can start to measure it.
Yeah, it's like what was 25% on this gentleman? Don't really know.
We know
If
that
you're at a monitor that you can set one up.
25% lowering your blood pressure, we know that's kind of made up.
Right.
It's there's no science behind it. No one's ever really kind of come up with a methodical plan of like how we can or where we can drop. And the rule of like this dropping the blood pressure 25% really came from the fact that dealing with patients who have persistently long-standing history of hypertension. So someone who lives at 200, someone who's non-compliant, whose blood pressure is always really railing that high, that's the one that you say, okay, I can't decrease this blood pressure too high because their brain is used to that map, that perfusion index, right? And so if I take away that perfusion index, now I can basically hypoperfuse their brain, and that's how we stroke them out. So it's in that patient that we have a long-standing history and we kind of freak out. This is why, like, when a patient comes into the emergency department, especially in like urban settings where they're non-compliant, hypertensive, you look at their past vitals, they're always hypertensive, and like people say, oh my God, doc, they're hypertensive, we got to take the blood pressure down. You're like, no, they don't. This guy's not going to take his blood pressure medication at home. If I try to drop his pressure down to what we believe is normal, then he's going to stroke out because he's not used to that hyperperfusion state. His body's used to that, right? So that's the kind of process we think of. So in those patients, yes, you want to be gentle in how you lower the blood pressure. Someone made up 25%, we ran with it, but there's really no rhyme or reason. But this goes to show you, this is why when you have someone in CHF exacerbation, right, whose blood pressure goes into 240s, 250s, we're totally okay with taking their blood pressure to 100 systolic even, right? Why? Because we know that this is an acute process, that their body's not used to having that high MAP index and requiring that high perfusion state to perfuse their brain, so we can even drop their pressure low and sustain it. So every scenario is different. So if you have a guy who's coming in, and like you said, Dan, you believe that pressure was an acute event, and you can drop it as low as you want to, no big deal. But really, the question is, when is it really relevant or really important? And literature has shown us that it really isn't, We don't have to drop it so fast. And it really was the bleeds is the ones that we really worry about. Other than that, not so much. And I think that's what you were thinking. And your thought process was, this guy's Cushing, he looks pretty bad. I got to decrease this so I can decrease the amount of bleeding that this guy's probably having already to begin with, because he's probably herniating, And so, in my opinion, I think he did the right thing in dropping that blood pressure quickly as quickly as you can, because you already see evidence of some sign of end organ kind of failure to the brain, really. And, what we deal with is always brain, heart, kidneys, right? So, numero uno is being affected, so I want to make sure I take care of that first. And then we can get them to the scanner. Because by the time, as easy as we say it is, by the time you package a patient, get the patient over, put them on the table, bring them back, you're 25, 30 minutes in. Versus I could actually resuscitate you for about 5-10 minutes and then get you over there a little bit more safely. So I think you probably did the right thing in really resuscitating them initially. And if you had a patient who's bradycardic initially, that I would be a little worrisome about giving labetalol to begin with, but if their blood pressure, their heart rate responded really well to calcium, that's great. I think that's super awesome. And that gives us a little bit more telling. Like, whenever someone responds to calcium really well, that's a little bit telling to me, and it's like, okay, I may be dealing with hypokalemia at this
I had
point,
far
right?
less of a concern
Yeah,
with being a
exactly,
bleed
exactly.
when within 2 minutes,
Yep.
the heart rate came
Because
right
it's like if someone didn't respond to calcium, then I'm still going on the same track.
Yeah.
But when they did, I'm thinking, all right, why is the bleed responding to calcium? That doesn't make sense, right? So and that kind of fits your picture. So a lot of that kind of helps. And is there any harm in giving calcium? No, I 100% agree with you. I would give it like candy. That's one of like my favorite drugs, out there. Ketamine and calcium. I think those two come hand in hand. But one thing I've seen anecdotally, and I don't know if you guys have seen this enough or not, if we really give calcium push dose, like fast, a lot of times they get nauseous and some of our patients vomit. And that's the one thing I have seen. So I always caution, some of my new medics who are learning, even my new nurses who are learning, to really give the calcium slow. If you give the calcium really fast, you will precipitate a little bit of nausea and sometimes some vomiting. And that's usually not a good case because sometimes these patients are pretty labile to begin with.
Would anybody intubate this person early? Well, he was conscious. But
Yeah, no. If he was not maintaining his airway in any way, sure, but
Yeah, I think
was
that's always
not
I think it's always a
high on my
clinical
list of-
picture. I've taken people with bleeds. The one thing is that if you do have a guy with a bleed, you want to spare that guy's neurostatus, right? And you want to be able to have serial neural examinations. One of the things that neurosurgeons hate is when we take an airway really quickly, especially in a neurosurgical case, because now they've lost the ability to really kind of examine them in a serial manner and see whether or not they need to intervene because there is some deficit that they're having. Certainly, if they're lethargic, stuporous, we have an issue with the airway, take it. No hesitation whatsoever.
Also, getting back to the calcium, if you have a patient that does become nauseated and does begin vomiting, now you've increased their intracranial pressure. So if they're having some sort of cranial pathology, you potentially could make that even worse. Got all the mics. And then the idea of increasing intracranial pressure with dropping that blade for a tube as well. If I can spare them a tube and keep that ICP down, that's probably better.
Yeah. Agreed. Any other comments? No. Let's go over. Who wants to do one of the articles?
I've got an article. So I'm going over the article. This was predictors of definitive airway SANS hypoxia, hypotension on the first attempt. -1A is the acronym, success in traumatically injured patients undergoing pre-hospital intubation. And I do have to say, using SANS in the title in order to get your nice acronym of -1A was spectacular. So this was an article that actually has been accepted for publication, but is really hot off the presses. So it's posted online on the 20th of September this year. So fresh, hot research. So this was, let's see, single center retrospective chart review that looked at patients with traumatic injuries and at least one attempted intubation by helicopter EMS at the scene. So the study basically looked at a few things. They had 263 that met their inclusion criteria. They were 95% Caucasian, 76% males, 90% of them had suffered blunt trauma. And so this was an interesting article because it actually looks not just at first pass success rates, but they really wanted to see if they could figure out what sort of risk factors, what sort of predictors went into getting a first pass success with no episodes of hypoxia or hypotension, which they described as this -1A intubation success. So they basically said 94% of their overall patients were successfully intubated. Let's see. So things that actually were associated with successful -1A intubation was, and these were kind of interesting, no EMS, ground EMS intubation attempt prior to their attempt, a lack of airway secretions in blood, a Cormack-Lehane score of 1 and 2, which I did have to review a little bit, but that basically means that they had a good view of the vocal cords and were able to successfully watch that ET tube passing. And then, let's see, bougie use. So they talked about also they went into what factors were associated just with first pass success, irrespective of whether or not they had hypotension or hypoxia. And so those were essentially the same thing, a grade 1 or 2 view, lack of secretions or blood, bougie use. So this was interesting because I know we could get into a firestorm of debate over this, but direct laryngoscopy was associated with first pass success, and not using apneic oxygenation, which it was interesting in the paper. They did talk about the fact that there are some other papers that may refute a few of these findings, and they don't recommend changing your practice patterns based upon, their finding of lack of apneic oxygenation. But yeah, so I mean, this was interesting. This was essentially a flight crew consisting of a flight nurse and a resident physician, or an attending, or a nurse practitioner, and they found that most of these people who were intubating were resident physicians that was performing the intubations, and almost all of these intubations were done using direct laryngoscopy. So it was kind of an interesting study. I think that in this case there was a few things that caught my attention as far as kind of the methods. So 91% of them had a C-collar in place at the time of intubation, which it's interesting that it was direct laryngoscopy and had a C-collar in place. They were actually intubated in the back of an ambulance, so not actually en route via or during the flight. Basically that was kind of it. The other thing is they did talk at the very end of the article about unreported episodes of hypoxia or hypotension being a potential recall bias, and I think that's important to really look at as far as these were all reported, like no hypoxia, no hypotension after the intubation was completed. So recall bias does kind of play a part in this. But overall, interesting study looking at some possible things. They do recommend, being more familiar with bougie. They do recommend, really taking a look at being ready with your suction to eliminate the possible, secretions and all that. So interesting study. What do you guys think?
Does anyone have any thoughts on that?
Yeah, I'll talk a little bit. I didn't read the paper directly, but Cormac-Lehane's like Malin putty once you're looking in the back of the throat with video or direct laryngoscopy. So if you have a better view, it's going to be an easier intubation. I say the big thing about Cormac-Lehane is if you probably reposition the blade when you're in the vallecula, then you probably can increase your Cormac-Lehane view. Anybody with less blood and secretions, probably an easier airway, going to be higher first pass success rate. As far as the apneic oxygenation, I don't see how that really impedes your first pass success. We know that hypoxia, acidosis, and hypotension are like the peri-intubation killers. So we resuscitate the patient prior to any intubation attempts, push those pressures. We nitrogen waste with apneic oxygenation. So I don't know. The paper to me seems like everything they pointed out to increase first pass success is stuff we all know. The apneic oxygenation, I definitely wouldn't change my point of practice now. I don't know if anybody else has anything to say.
And I mean, even then, I think this falls into that category of at a 95% confidence interval. That means that 1 in 20 times you're going to receive something that probably has a type 1 or type 2 error, right? So this may be just one of those times in which this was just a weird, fallacious. I think there's plenty of research out there that shows that apneic oxygenation is, strongly associated with better outcomes. So, and they even in their own paper said, yeah, this is probably just weird.
I'd be really interested to see actually, like, because when you actually choose not to put oxygenation, when it's more or less the standard of care, at least now that we feel in this modern age, which patients did they choose not to use apneic oxygenation on? So there's a subset of population that they're probably choosing not to do it on. So if I'm thinking, what patient would I probably not want to use apneic oxygenation on, or not want to, or not do? I think it'd be the 20-year-old trauma patient who I'm just tubing because it's managing the airway, right? And I mean, that patient, it's going to be an easy airway because they're young, they're healthy, they probably have no risk factors, and it's a trauma. It's like straightforward. So I think there's a lot of bias, and when you start saying, I'm going to deviate from my normal plan when you have a patient, if you have a sick patient who's hypoxic, what are you going to do? You can oxygenate that patient to begin with, put them on an on breather. And so setting up your tube, your blade, and everything, you're already doing all that stuff ahead of time. So you've already knocked out a very large subset of population, the sick population. And those patients are going to be more challenging. Those patients are going to be a harder tube to get. So if you just think of the bias that comes with it, and which patients would you think about, why am I not following my normal train of thought or my normal pattern? It's because it's probably something straightforward. Or it's probably a cardiac arrest, or something that, you think of like, why did I not put someone on oxygen in order to set up my stuff? Because I just went in and just tubed them. So what was that patient? Who was that patient? And so that's kind of, when I think about that, when I think of like sometimes, why does someone deviate from their normal plan? It's also interesting in this article that you have a lot of younger physicians who are going direct, which is usually not the case, which is kind of interesting. A lot of times, like the younger residents and some of the people who are in residency are going more towards video, and they're usually a lot more comfortable going there and versus direct. So it's really interesting to see the fact that they actually did use direct laryngoscopy, which I think is great. Everyone should have mastery of direct laryngoscopy, and that's a credit to their program. But I think that's interesting to see that they actually did that in a younger group of physicians.
Reading the chart correctly, if I'm reading the table correctly, they were looking for provider, they were looking for patient, they were trying to determine what what helps for first pass rate. It wasn't as far as the p-value and even the odds ratio. The being a resident PGY1 through PGY4, and even as a attending physician, although I think they might be referencing a nurse practitioner as the standard, I don't know. It wasn't stats significantly. So in other words, it doesn't matter whether you're a PGY1 or 4 intubating a patient. And I think we clearly understand that it does matter whether you're a first or fourth and you're already that trained, senior resident. And even as an attending physician, some people would argue that, like, depending on how many years out you are, like, sometimes it's even better to have that fourth or third year resident intubate rather than attending physician. So it's interesting to see that.
Yeah, what it comes down to is how many intubations you've done in the last year. No matter what, skills deteriorate, and if you're not intubating enough, you need to refresh. Also, the tools that you use. If you're not familiar with your video laryngoscope, that's why a lot of people fall back on direct, because that's how they trained when they were in residency, and that's what they're comfortable with. I mean, I did a direct intubation for like the first time in a year a couple of weeks ago, and I was just like, is this supposed to be that small, the vocal cords? Because now I'm so used to fiber optic, I'm so used to video where it's like nice and enlarged, and I was just like, no, that's how it always is. I just haven't seen it in a while. And then when you work with learners, so like I work with a lot of residents, I work with a lot of anesthetists or even respiratory, where they'll be doing the intubation because I could be doing something else while they're doing that, and you learn a lot. And then to what Dr. Norris was talking about, where recall bias is huge, because if someone asks you, oh, did you get that on first pass? You're like, hell yeah, I got it on first pass. And it's like, did they DSAT? I'm like, well, I didn't see the DSAT. And that's why a lot of protocols will either use video or they will actually have research assistants basically sit there with a clipboard and then rate you based on that. These are things that go on a lot. And then also what kind of intubation, if it's difficult. Do you think that it was right that they took out people who had prior intubation attempts for this study? They took out people who had prior intubation attempts. And I feel like that's a good thing to do, because we all know that when someone else has tried to intubate before us, things are different. There's swelling in the airway. Just manipulating the airway, things are different. It's much, much harder.
Yeah, and I apologize, but actually they included patients that had prior airway attempts in the ambulance, because that was one of the things that predicted a more difficult airway attempt, which is understandable, not only because if EMS has tried it and it failed, then you got to assume that it's a difficult airway. Also, if EMS has tried it, then they've caused some of that trauma in the airway, so they probably increase risk for. Then they talk about it in the article of increased risk for bleeding and increased risks for
it's just another
edema.
Risk factor, basically.
Yeah. If they were successfully intubated prior, then they were not considered in the study. So you also have some selection bias there.
One of the things I will think about, just thinking about why would a resident not use video laryngoscopy, and I'm thinking, again, I'm trained from an older generation, like where I was only taught on direct, and so I'm comfortable just doing completely direct. And I was hesitant to go to video, but now I'm sold on video because I think it's great. Now the question is, why would someone move away from that? I mean, if they have that in the department, because most residency programs have it. I think my own opinion is this: is that when you go to most emergency departments, we usually venture between one or two styles of video laryngoscopy, which are pretty widely available. When you talk about helicopter, those are bulky and heavier, and they're probably not the go-to. So we have lighter, more portable video laryngoscopies. And so, like Pranali, if I told you, like, you're a resident now and in one of our ERs rotating with us, so if if I gave you a McGrath to use as video laryngoscopy to tube a patient, do you know what a McGrath is?
No.
Right. So if I said I could give you a video laryngoscopy, or I can give you your direct blade, which one would you use pre-hospitally?
Just direct.
A direct, right? So I think there's some bias in that too, because you're not used to the video laryngoscopy that you have of choice that you've trained on. And this is why one of the things that we do in our fellowship is that we have multiple tools and multiple video laryngoscopies on our units, because we want all our fellows to be well versed on the different types of video laryngoscopy that they're available. So that way, wherever you go, whatever you're handed, you can actually be comfortable using it.
More importantly, when you guys, take over a system or a fire department or something like that, you can decide, well, which video laryngoscopy do I want to put on my medic units? What do I want to use? Do I want to ding people or give them the option to choose what to use first? So some agencies will say, you have to go video first. And I'm not saying that's right or wrong, but if you have a higher first pass success rate, why wouldn't you? My answer to that is that you have degradation of your other skills then. You should be able to, you don't want to go to your backup and have your backup be like, oh crap, how do I use this thing? I think that you should have options on what to use, and especially when you have another medic with you who is more experienced, they know that they're going to get it with a video. They know they're going to get it with a direct, so you should be using the one that you're not used to.
Is everyone going straight to video here?
I go direct.
Yeah. Okay. Yeah. Same. I always go direct. I don't even think about video until it's my backup. And it's funny because the other day I was intubating and the nurse was like, "Oh, you're going direct? Like here we always do video." And I remember I had like a grade 3, grade 4 view, and I was asking for a Mac 3 to a Mac 4, and then I couldn't see it still, and I asked for a bougie, and they were just surprised at the fact that that I was doing all that rather than going straight for a video. But I think with the different grades of view on the chart and the odds ratio, I think it's also a good teaching point when you're now as an attending, when the resident or anyone else intubating is there. And I remember as a resident, a lot of the attendants would always tell me like, hey, what's your view? What's going on? What do you see? And I'm just like all focused in there. But now I can understand, if I have a resident, I want to know, wait, what's your view like? So that if it's a 1, you have an odds ratio of 86 of, most likely getting through the vocal cords. And if it's a grade 2, then it's a 6. And then you have to start thinking about, okay, now what's the next step? Is it going to be bougie, or, do you need some cryopressure and all that? But you won't know unless the resident is reporting to you and letting you know where you are.
I think with any, most video laryngoscopy, especially if it's performed in the ED, the video's on a standalone unit so other people can see. Even when I use video laryngoscopy, I'm looking direct. I'm just using video, maybe because I'm anticipating this super difficult airway and, a certain type of patient, but I'm still looking direct, watching the tube pass through the cords.
Or if you have PA students or medical students and you want to teach them, in the process of what you're looking at and how it is to intubate, it's helpful.
So my favorite use for video laryngoscope, especially in a teaching environment, is the one with the less acute angle. So we have acute angle video laryngoscopes, and we have ones that you can actually use the scope as a direct, and it just has a video component to it. I like that because when we actually go ahead and intubate, I like the screen to not be facing the operator. So that's for everyone else to be like, I don't have to be like, what do you see? That's why, in a teaching environment, having direct is like, oh God, it's like, why isn't this done yet? What, let's just start bagging the patient. When you actually can see what they see, and actually you see a more acute angle, it's much more relaxing. Because you're just like, oh, just move to the left, pull out a little bit. Okay, there's your view. Now just push the tube through. And then they can't push the tube through. At least the view is there. So you can even grab the tube and put it in yourself. Well, that's the problem with direct, is that it's very user dependent. And then how do you teach someone when you have to be physically in their space? So I think we talked the video laryngoscope to death today. And then prior to that, any more comments? I think we'll wrap up Journal Club for today. Everything's posted on the EMS Fellowship website. Next Journal Club is next week on Wednesday after MAB. So, all right.